the more cases I do, the more patients I see, the more surgeries I do, the further I'm actually getting away from that patient-centered care. Why? Because I work with 2 or 3 physician's assistants. So now they're seeing my post-ops or my pre-ops, right? They're seeing the patients before and after surgery. So that's great, but I don't have as many touch points. So the more surgeries I do, the less I get to see sometimes, because I need to be able to do more surgeries to help more people.
Welcome to the Prehab Podcast, where we dive into expert insights, connect with industry leaders, and share real stories to help you take a proactive approach to your health. I'm Dr. Arash, and today we're joined by an incredible guest, Dr. Nima Mehran. Dr. Mehran is a world-renowned orthopedic surgeon and a sports medicine specialist. He's highly published and has won several prestigious awards and has trained at some of the top medical institutions. His career has included serving on medical staff of major sports teams like the Lakers, Dodgers, Kings, Ducks, and USC football. Before we jump into our discussion, I want to acknowledge that this episode was filmed shortly before the devastating fires in the Pacific Palisades. This tragically destroyed Dr. Mehran's home and private practice just 1 week before he was set to open the doors. Despite this heartbreaking loss, he remains dedicated to serving the community, and he's currently treating patients at an alternative location in Santa Monica while he's working to rebuild. In today's episode, Dr. Mehran will share his expert insights on all things related to the knee. Whether you're dealing with a knee issue yourself, you're a healthcare professional, or simply curious about the latest advancements in knee surgery, this episode will offer valuable information for you. Today we have Dr. Nima Mehran for not only the first time or the second time, but the third time. Nima brings so much value. Thanks for coming on, Nima, for this third time.
Thanks for having me, man. I always enjoy talking to you guys very much.
Hopefully we can make the third one the best one. All right, so I got to get something off my chest, Dr. Nima. For those of you that don't know, Dr. Nima and I play paddle tennis weekly for the most part, and he's my arch rival, in addition to being an orthopedic surgeon. Now, a question I have for you is, what's more difficult to manage, a complex knee case or keeping up with me on the paddle courts?
I don't know. I think I'm the only one that's ever won 6-0.
Good call. Nima's gotten me into it. It's a great sport. I recommend it, especially seeing all the stats with longevity. Apparently, it makes you live 10 years longer. So, anyways, paddle tennis is a great sport. 6-0, those days are over, unfortunately for you. But cool. Let's jump into what I wanted to get into today. So, the first thing I wanted to talk about is your journey. Now, you've been through a couple big healthcare systems, and you've moved over towards a private practice, which is unconventional, especially for your role. Take me through that thought process and the decision-making that you went through as you kind of decided that was the best next move for yourself.
Sure. So I think when I look back at my career, my journey, it all starts with patient care, right?
Yeah.
And so when it starts with patient care, my goal has always been to be close to patients and to develop that relationship where you know them, you know their family, you know their interests. To really take care of them well, it helps to have that relationship. And in the process, going backwards and looking at these large healthcare systems, it's one of the best places to start your career. As a resident, you get to see more complex cases. You're doing higher volume. You have extra help with more experienced surgeons, and even as a young surgeon. So it gives you the opportunity to grow. It gives you the opportunity to learn more, the opportunity to see a lot more patients. And so there's a lot of pros of these large healthcare systems. In the early career, it seems to be all pro. But the further you get in your career, you start to realize that, even though you have all these wonderful things and you're learning and you're getting better, your patient skills are better, your surgical skills are better, there's something that's becoming more and more difficult. The more cases I do, the more patients I see, the more surgeries I do, the further I'm actually getting away from that patient-centered care. Why? Because, for example, I work with 2 or 3 physician's assistants in these large healthcare systems. So now they're seeing my post-ops or my pre-ops, right? They're seeing the patients before and after surgery. So that's great, but I don't have as many touch points. So the more surgeries I do, the less I get to see sometimes, because I need to be able to do more surgeries to help more people. So that patient-centered care kind of gets less and less. I don't get to spend as much time with people. in these large healthcare systems. I don't get to know everything about them and their desires or their family members. I don't have that close-knit relationship, which is kind of a downside. And so in that process, as things have changed in the United States and we have gone through, think about our childhood. In our childhood, we would never have fathomed that you could press a button and the next day, whatever you thought about could show up at your door, right? My daughters, they love Taylor Swift. If they wanted, I could press a button on Amazon and tomorrow morning a Taylor Swift poster is at the door. Mm-hmm. So that's the same thing patients are going through, right? They can now press buttons and they have more access, and their demands and what they want healthcare to be is crazier than we could keep up with. So in these large healthcare systems, I now have less time with them, which is setting me up for more emails, more messaging, right? And they also have higher demands. They want faster service. They want to be able to call on you or text you whenever they want. So between the demands of patients, which are fair, right? We have better technology. The expectations are higher, but we are doing more non-medical stuff, more emails, more paperwork. So I find that I began to spend less and less time with patients and less time with the thing that got me into medicine, which was patient care. It's the part I've always enjoyed, getting to know you, getting to know your desires, getting to know your goals. And so now I got to that point and I was like, well, I've learned a lot here. I also helped manage a department. So I took care of a lot of other surgeons and helped our practice grow as a group. We had a large department in our department, between surgeons and physicians assistants and medical assistants, 100 people or so.
Right.
And that's a wonderful thing. But I wasn't able to concentrate on what brought me into medicine. Back to that patient-centered care, back to the relationship, the conversations. And I missed that. And so I was getting further and further away from that. So my thought process was, I want to go back to a little bit less volume, more time with patients, more concentrated care, more care on the things that I enjoy, the surgeries that I'm good at, the patient population that I enjoy taking care of, who are matching my personality. They have the same intensity or goals and they want to get better and keep growing. And I want to give them as much of me as they're giving themselves and their goals. And so we can drive each other and get better and know their life and be a part of their community. And the only way for me to do that was to start something fresh and be in control of everything, as well as be able to decrease the volume. Instead of seeing, tens to hundreds of thousands of patients, we're seeing a smaller volume, hundreds.
Right.
And I love the idea of that. It's more personal. I can concentrate on quality. And that's a tricky word because that makes it sound like quality is not good in the large healthcare system, but it is. It is for most things. It's fantastic quality, especially for everyday things, right? Like knee replacements and things that you do all the time. But there's a certain subset of patients, and those patients really want your time. They have more complex cases. They want you to know what their goals are, and that's what I want to do also. I want to give them more time. And so my quality can improve with access to me and with the time I'm spending on their imaging and on their exam, rather than the time I'm spending on emails, which would get higher and higher and volumes of emails because I was spending less and less time with the patients. It was a bad cycle for me. And I wanted to go back to what drew me into medicine, was always taking care of patients, not becoming more administrative or.
Totally. No,
hopefully that makes sense. That was a long answer.
No,
but
that's great.
It's a complex.
I didn't even think about the demands of patients increasing over time with how accessible it is to message and email your physician. What do you think? And that makes sense for us as well. That's why we created Prehab Physical Therapy, is to go out of network, to make it more accessible and allow for patients to come in without restrictions of their insurance. And that's the same idea that you're talking about there, is you provide the care that you think is best regardless of any restriction. Now, when it comes to the healthcare system as a whole, what do you think could be a solution to help that piece of it? It's a very, very complex question, but I know there are a lot of efforts towards trying different things out. I wanted to see what you think.
I think that's the $1 billion question or the $1 trillion question, right? I mean, if someone had an answer to that, that would be, you'd solve a lot of the world's problems. But I think when we were kids, you go see a physician and the physician was writing notes on a piece of paper about you, but you'd walk in and they knew you, they remembered you, they knew your parents, and they say, hey, Arash, do X, Y, and Z, follow up in 6 weeks. During that 6-week period, you were doing what they told you and you were waiting to follow up. We didn't have this access that we have now, right?
Right.
So that physician was really concentrating on patients. I think to solve healthcare, we need to have a greater volume of people going into healthcare, right? So we need to have a larger number of physicians, larger number of nurses, physician's assistants, because our patient to practitioner ratio is just way too high. So if we want to truly make a difference, we need to go backwards to go forwards. We need to take 2 steps back to take a step forward, and we need to concentrate more on the quality and the time. And right now, with tech is supposed to create a more efficient world for us, and it does in some ways, but it's also made us spend less time with patients.
Yeah.
And so I think the only way to solve the healthcare problem is to, one, make medical schools and nursing schools and PA schools and PT schools either free or a very small amount of money, because then by doing so, more and more people are going to be willing to go and take care of people, right? Even if the salaries aren't as high as they used to be. I think with teachers also, healthcare employees, make them governmental employees, right? So if you decide to work for in healthcare, these larger systems, and you have great benefits because you're a part of the government, and the med school's free, your PA school's free, your PT school's free, more and more people are going to go into it. They have a good salary, good benefits, and they're not worried about this massive loan that they have to pay off.
Right.
And so we're going to drive up the numbers, decrease that ratio, that patient to healthcare provider ratio, and that'll help us, because right now resources is the biggest problem.
Yeah, no, it makes a lot of sense. Actually, last year, there were more PTs that left the profession than actually joined the profession, just to show you how we're moving the opposite way, at least with PT. And it's difficult because you see the trend moving the opposite direction, but the supply and demand analogy that they use makes a lot of sense. I know for us, a lot of what we're trying to do is teach a more proactive approach and minimize the need for people to even go into the healthcare system entirely. Right now, when I last checked, it was like 3% of healthcare dollars are spent on preventative care. Most of it is reactive care, which makes sense, is you need to make sure those issues are solved for first. But that will hopefully declutter the system a little bit. But no, that's great. That makes a lot of sense. So now transitioning towards your day-to-day, let's focus a bit more on the knee. We got a knee model right there. What are the most common knee cases that you see nowadays?
So the obvious, right? The ACL injury in young athletes. I see more ACL injuries and meniscus injuries than anything else. And then of course, knee arthritis, right? That's one of the most common diagnoses in the knee. Those are the 3 most common things I'll deal with on a day-to-day, but then other sports injuries, including multi-ligament knee injuries. I've been dealing a lot more with the meniscus transplant and the cartilage transplant cases. That's one of the benefits of a larger healthcare system, is that you get to, those cases can cost a lot of money and take a lot of resources and take a lot of time. So smaller practices have trouble managing that sometimes, because you have to get very fast and efficient. But over time, if you do that in large healthcare systems, you get fast and efficient enough at these cases, you can be on your own and actually be able to manage those cases well enough and efficient enough to still not cost a center too much money, and be able to perform these cases that can be so heavy in cost. So, but meniscus transplants, cartilage transplants, I love taking care of that kind of stuff, because a lot of those patients are the ones that have hit a road where they're in pain. They don't want their knee to head towards a knee replacement, and they want to conserve that health of their knee. And so we have to do procedures that not as many people do or can do or have the resources to do. And so I love those more challenging cases.
meniscus transplant and cartilage transplant. Those are a bit newer, right?
We've been doing them for a while. Our technology is just regularly getting better.
Yeah. So of those injuries or of those diagnoses, which ones, what percent of those end up needing surgery that you end up seeing in the clinic?
Okay, so that's a great question. It's a low percent. Like if I'm seeing, let's say I saw 30 patients, I'm probably booking somewhere between 3 and 6 surgeries. So the majority of the cases I see don't require surgery because most people are seeing me for just pain,
right?
Weakness. It's not always the surgical needs. A meniscus is the most common thing that I'll see that doesn't always need surgery. In a lot of meniscus cases, so most commonly it's someone who's 50, 60. They have a meniscus tear, but they also have very obvious arthritis. And if I go into their knee, I usually can't repair that meniscus in every case. And in most cases, you're just kind of removing a little bit of it. And so now the knee is being set up for further arthritis. It might help them in the short term, but they have less of a cushion. And if you have less of a cushion, right, less support over time, that arthritis or the narrowing in that joint is going to continue to progress. And so I try really hard in cases like that to manage them non-operatively. Physical therapy, injections, anti-inflammatories, anything you can do to get them stronger, get them more mobile, a little bit of activity modification. I have those patients keep activity logs. Like, what are you doing? How long are you doing? I want them to be as active as possible for as long as possible. So if I can get them to, for example, for us, if we were playing paddle tennis 5 days a week and the person says they have pain after an hour, hour and a half, well, maybe we can play 3 times a week for 45 minutes to an hour. And you can keep that going for a little bit longer. I want them to not go to surgery. Surgery has to be the last option, right?
Yeah.
But on these ACL cases, if it's a 21-year-old, collegiate basketball or soccer player, lacrosse player, they want to go back and they have a full-blown, torn ACL and they have, obvious instability. If we don't fix that, if we don't give them a more stable knee, we're putting them at risk of damaging more cartilage or more meniscus, and we don't want that. So it just depends on the case by case, the age, and most importantly, what are their goals? What are their activity level?
Makes sense, yeah, with that needs analysis. So yeah, with like the ACL, we got to get back to that rotational sport. You got to have that stability there. Same thing. I know in the meniscus podcast that you did with Mike, talking about catching, locking, or clicking with the meniscus, indicative of likely needing some type of operation to open that up.
Yeah, especially locking, right? And one of the most things that, for your followers who are actual healthcare professionals is you want to always check that other knee because somebody might have 10 degrees of hyperextension on one knee, but their knee, they have pain on their joint line and they are straight. They're perfectly at zero, full extension. Their knee might be locked because they're not symmetrical and they used to be. So there's something that could be, they could have a flipped meniscus. So you always want to compare to the other side. And a locked knee is something that's much more serious than just a regular meniscus tear who has, just a little bit of pain. You can manage that non-operatively, but a locked knee, this is a person that could require surgery for repair of the meniscus, or, you also want to get them in surgery because you don't want their tissue to continue to contract and then they never get their full motion back. So it's a much more urgent situation.
Makes sense. And then what about a cartilage defect? Like that, I know that's maybe a little less straightforward, but what's the algorithm, the thought process there?
So that's one of the more complex things, right? I always say when some patients will come in and they see marketing and they think it's very easy to recreate cartilage.
Yeah.
Like we're not hiding this magic injection or magic pill, right? Like no. I wish, if I always say, if I could think of that, I would change the world. We'd have the fountain of youth and I would be a trillionaire. Yeah. And I win a Nobel Prize, probably twice, right? Like how amazing to change the world like that. Yeah. The problem is with cartilage is it doesn't have blood. It doesn't have nerves, right? So it's hard to heal something without the nutrient blood, right? So if the defect is small and it's localized, imagine driving on a street and you see a little pothole, right? You see a pothole, someone comes in, we can either, there's a microfracture. Microfracture was an older technique we used to use that we don't use anymore. What you do is you poke little holes in the bone underneath the cartilage that's missing, and then it creates a new layer of a different type of cartilage. That's been kind of shown that over time, it doesn't do well. So a lot of us have gone away from that, but another example of something we can do is we could take autograft somebody's own cartilage from an area they're not really putting their weight on. And we could take a small plug, about a centimeter or so, and we go and plug it in if you have a centimeter hole. And that could really help you because we're taking it from an area where you're not having weight in your knee to an area in the center of your knee where you're putting weight. So that could help someone. Or there is an osteochondral allograft. We take it from somebody who's passed away and then we plug it into your knee. These are all for solitary potholes, like on a street. And there's also something called MACI, right? MACI is when we take your cartilage and we go into a first surgery. We take a little, a Tic Tac size cartilage in an area called the notch where we don't really put weight on it, right? And then we send it to a lab, they grow it, and they form this matrix, and we go back and we put it and we cover the pothole with a little bit of a glue and a cartilage matrix. Okay, that's your own cartilage. So these are the 4 ways we can kind of manage this cartilage, surgically, right? Because obviously you always try physical therapy, anti-inflammatories, injections. But if you in the surgery world to manage those things, you can do those for solitary lesion. But what if somebody has massive diffuse cartilage loss? That's arthritis, right? That's like driving on a street that's completely gone. The whole thing needs to be redone. And that's why we do a knee replacement. There's nothing we can really do. But in cartilage injuries, the best way to manage it to start is always start out with physical therapy. Always give the patient time to see if they can manage it non-operatively. Depends on where the location is. If it's in the patellofemoral joint, right? If we're right underneath the kneecap, you're not putting your weight on it, so it might be easier.
I've seen a lot of mild to moderate knee OA do very well with PT.
Absolutely. It's the way you should start. But if someone's not getting better, if they're having recurrent effusions, so recurrent swelling, and then pain, and you tried injections, you've tried PT, you've tried everything, then we start going down what procedure can we do? How successful can it be? And are you a candidate for which one?
I'd like to take a quick break to introduce today's sponsor, Jane, a clinical management software and EMR that has changed the game for us here at Prehab PT. Switching your software can feel intimidating, but Jane makes the process easy, providing you with onboarding resources and 10 out of 10 customer support to make the transition as smooth as possible. If you're interested in learning more, book a one-on-one demo at jane.app/switch. And if you decide to make the switch, don't forget to use the code PREHABGUYS and sign up to receive a 1-month grace period on your new Jane account. You won't regret it. And there are some tools out there to change the demands of your knee with like an orthotic. Are there surgeries to change the alignment that you have based on the demands of the cartilage?
Absolutely. That's a great question. So that is one of the surgeries that I enjoy the most, and those are osteotomies. So one of the things that happens over time is you might have like a 16-year-old kid and they have a really bad injury, terrible injury playing soccer, for example. And they go in, they get their ACL fixed and their meniscus wasn't repairable and they had a large partial removal, or we call a subtotal meniscectomy. You just lost almost all your meniscus. And now that joint space is beginning to narrow. They don't have a cushion in there, no shock absorber, their meniscus is gone. And they're starting to bow, right? So if it happens on the medial side, their knee will go bow-legged. If it happens on the lateral side, they might become more knock-kneed, right? So what I always do on every patient that I do knee surgery on, particularly more complex things, is I take an alignment film. And when I draw a line from the center of your hip, it should go right through the center from the center of your hip to the center of your ankle. It should cross the center of your knee, right? So if we do that, and that line drawing from the center of your hip to the center of your ankle is sitting all the way to the outside, that means you're really knock-kneed. And if it's all the way on the inner side, that means you're really bow-legged. So if we do anything without adjusting that alignment, then we're setting whatever we did up for failure, whether it's a meniscus transplant or plugging that cartilage defect, because there's still too much pressure going through that side, right? So if they have a cartilage defect here and they're bow-legged and all their pressure is going through that side and it's going right through the defect, if I don't align them correctly, it's a problem. So sometimes some people will do it all at once. Others will actually do the alignment procedure first, make them straight. And you'll have a patient population, a subset that'll come back and say, "Doc, I feel great. Now that my weight's not going through that one spot, I'm so happy." And honestly, these osteotomy patients, wow, they have some of the most successful results. And I love taking care of them because they're genuinely happy and they feel better.
That's crazy. Yeah. Where do you pull the bone from in the osteotomy? Is it
what do you mean?
Like how are you realigning?
So, okay, great question. So what we do is let's say, for example, the patient is very knock-kneed. Okay. One of the things I can do is I make a cut at a diagonal angle in their femur and their thigh bone. And then based on my measurements, I gap that open. And if I gap this open, I start straightening their knee because I'm gapping it open on the outside, causing their knee to go centrally more inwards. Okay.
Got it.
So based on the measurements of how knock-kneed they are, I will now gap that open a certain degree. Some people will leave it open and put a plate and screws, but the alignment's now correct and they check it during surgery. I actually like to take somebody else's bone and I like to fill that hole as well. I find that it heals a little bit faster, a little bit, more reliable, and the patients seem to be in less pain earlier on, anecdotally in my experience. And I think it's just a fantastic surgery with great results.
Yeah, I haven't seen people that have received that. That's why I'm
curious.
Asking so many questions about it. How about if someone's still in puberty and they're growing? Is that something that you can take that into consideration still?
Yeah. So then, you can do that earlier on. And in fact, some people do it. A lot of surgeons will do it for things like CP, cerebral palsy. And these pediatric surgeons, they do magnificent work. Major shout out to one of the places I trained was at Gillette Hospital in Minnesota. And it's one of the best CP clinics and centers in the country. And this hospital, it's so touching. They take these kids and a lot of them are in these bad positions, right? Whether valgus or varus, right? So knock-kneed or bow-legged. And then a lot of times they have contractures. They can't walk right. So in this population, they do these derotational osteotomies and they rotate them in the right position and they align their bones differently to take pressure off some of these tendons to help them walk, to help them be more, be easier to take care of. And it is unbelievable the results that they have and, the difference that they can make in those kids' lives. Now, if we do it in someone who just has, one valgus knee, so one knock knee, for example, and everything else is normal. Sometimes, depending on where you put the plate, you may have to remove it earlier so you don't affect growth. Sometimes all we do is in a lot of kids, if they're like, for example, growing more, causing their knee to go out this way, we might put a tiny plate around their growth plate to cause growth arrests on the other side to get them to straighten out while they're growing. Right? Those are not surgeries that I do. Those are more the pediatric ones, but they have really, really good results. And so it's important if somebody has one limb that's going outwards or inwards compared to the other to just see someone and have x-rays and have that alignment film.
That's crazy.
Yeah.
You rotate someone like that.
Oh yeah. It's amazing.
Yeah. What about any new advancements in the field? What are you seeing nowadays that it maybe has been different in the last 5 to 10 years?
It's great. So I think the biggest, the parts of the field that we are most curious about and is expanding the fastest is in 2 locations. One, biologics, so different types of injections, right? And then number 2 is like robotic surgery and things like that. So with biologics, we have PRP, right? Platelet-rich plasma. We have stem cells, all these different types of injections, and they have been shown to have some success in certain situations. The problem is right now people are so excited about these things. We're trying to use them kind of everywhere and anywhere, and they're not like this magic wand that you can just make everything better. But that realm is headed towards the biologic realm is headed towards a realm that's very interesting, and we're really curious to where it's going to go. Yeah. And on the robotic side, what's really interesting is we're able to take surgery and make it more predictable, and the results biomechanically, like our cuts, our angles, more reliable. And we're trying to see if that actually is demonstrating any significance in the clinical world, right? Because there are some studies will say, hey, now that we're using a robot on your knee replacement, all the cuts look better. They're more perfect angles. But clinically, in some studies, it actually hasn't shown a difference yet. It might show in more studies in the future. But like the robotics is pretty impressive. And what I'm most curious about is actually not that stuff. My mind keeps thinking about the ability to operate on someone in a remote location. And we're seeing that with some animals and things that they're doing this on in other countries right now. But imagine if I could operate on someone in an underserved community in the middle of a small town in Africa because there's a robot there and a surgeon can be controlling it in the United States or, in a different country. That would be really cool. Like, I think the ability to touch people and help people all around the world who don't have access, by being able to put robots in these places and being controlled by humans elsewhere. That to me is the most fascinating.
That's crazy. It seems like, from what I've seen, at least, robotics are more popular with replacements,
of
like
course.
shoulder, knee, hips. Or is it completely hands off in terms of you managing the robot? Or
no, they just you basically have the system. The way it works is it sets it up to help you make cuts at the proper angles and positions, because the robot's guiding you, but you're still doing the work. Now, in other fields, and like urology and other fields, you sometimes are guiding a robot, and they're doing precise work. So it just depends on the field. I think robotics and orthopedics is going to just blow up. Over the next decade. It's just, where is it going to go? Yeah.
Because I was just thinking about when I got LASIK on my eye, it was pretty much all robotics. It seemed like, at least from my perspective.
Yeah.
And so that's where things can eventually, I would imagine it's just a matter of time.
Sure.
It's probably more difficult as you're talking about soft tissue related injuries, I would imagine, compared to like a replacement. But then what about going back to biologics then? How often is it where the biologic is done with the surgery at the same time versus doing it separately? Because I know some people have the thought of, let me try to speed up recovery with maybe something like PRP or stem cells. And then there's another thought of the conservative route of just trying this as opposed to surgery, see what benefits I get. And then if that does not work, then go towards surgery.
You're asking some great questions, man.
Thank you.
Also some controversial ones.
I want to just know
putting me on the spot. Right?
I want to know the truth.
Okay, so that is a little bit of a controversial topic, and the reason it is because let's use ACL for example. When I drill a hole into your bone, right, and I'm going into your bone marrow because I'm going to pull a new tendon into your bone, there is a form of your own natural bone marrow, stem cells, blood, right? That's being released.
Right.
We don't have necessarily great data showing that in fact, we have data that shows that it doesn't really make a difference. If I take PRP, right? If I take your blood, I spin it down, and I take all the platelet-rich plasma, which has been shown to have positive effect in certain situations, and I put it into your ACL when I do the surgery, it's been shown that really does not improve anything. In several studies. So there's a school of thought for some people. It's like, oh, hey, I'm doing this surgery. I'm doing a meniscus repair. Let me add some extra stuff in there to help inside bleeding, right? And there's a school of thought of some other people, for example, like with this ACL example I gave, I'm already drilling a hole into your bone and all your own stem cells and blood flow are coming out. So why do I need to get more blood, create more costs, and put it into your knee when there's no difference in the results? So it's a controversial topic where I think this stuff has so much value, this PRP, stem cells, things like that. Particularly, like PRP is actually not when we're doing surgery. It's when we're not doing surgery, right? It's in tendinopathy. When your tendon is diseased and it's not healthy and it's having trouble creating brand new blood flow, right? PRP or stem cells, these kinds of things can be useful in this location because we're trying to incite healing. We're trying to create new blood flow, angiogenesis, right? We're trying to create new blood flow. And by doing so, your tendon, which we don't want to take to surgery and take out bad tendon and cause you to have, a bad result. We want to just incite healing in a non-invasive way. This is the best thing we can do. We can inject tendons with things like that, partial tears. That's where I see more value than ever. I'm already operating. I'm creating bleeding in your body. I'm creating holes in your natural stem cells and then adding to that. So I prefer it in non-operative ways. And so whereas PRP, for example, been shown to be most successful, we've seen success in tennis elbow, tendinopathy, right? We've seen success in rotator cuff tendinitis and partial tears, tendinopathy. We've seen success in knee osteoarthritis in mild cases to moderate cases versus placebo or cortisone. So these are more in degenerative cases. But we don't see a lot of evidence showing us that if I do surgery and I add this, it's better.
Makes sense. Yeah.
Yeah.
Yeah. And in that case, if someone wants it, it seems like it's more of a why not if they're really pushing for it.
Yeah. Or if they can afford it and they're like, you're fixing my meniscus. I would love it if you put some PRP or stem cells. There's no evidence that's going to cause harm. It might help. I can afford this. I'd rather have you do it.
Yeah. Even if the percentage is small then at that point.
Sure.
Okay. That makes sense. What about doing like an LET with the, any sort of rotational athlete? I know that's something that seems to have been a bit more popular these days with the ACL.
So LET, for those who don't know, is a lateral extra-articular tenodesis. And what that means is everyone can feel their IT band, which is the band that goes from your hip all the way towards your knee. And that band, which is really prominent down here at the top of at the bottom of your thigh bone, we take a slice of that, a sliver of it, and it's attached to Gertie's tubercle, which is on your shin bone. That's where it attaches. And we take a sliver of that, about a centimeter or so, and we take about 8 centimeters in length, a centimeter in width, and we slide it underneath your LCL, which is over here, and then we attach it to your femur. So it's still attached here, and now it's attaching here to your femur. So it provides extra rotational stability. A lot of people feel that in patients who have grade 3 ACL tears, this really unstable ACL, those patients pivot. They naturally rotate.
Yeah.
So you'll see them, I don't want to rip this off, but you'll see them do this.
Yeah.
And so by taking this and adding it to their ACL reconstruction, what you're doing is you're creating extra stability and you're decreasing the rate of an ACL re-rupture. So some studies are showing 2, 3, 4 times less ACL ruptures after ACL surgery if you do it with the lateral extra-articular tenodesis. So a lot of people will say, well, why don't you just do that in everyone?
Right.
I've actually gotten much more aggressive about doing them. And, these studies are in particular patient populations, but who I like to do them in is hyperextenders because they have a higher risk of re-tear. Younger people, particularly females, because they have a higher risk of ACL injuries. As we know, females tear more often than men. And so if I have a patient playing a high-risk sport, soccer, basketball, lacrosse, they're young, they're a hyperextender, they're female, I want to do a lateral extra-articular tenodesis because I can lower their risk of re-tearing their ACL if I do them together, an ACL plus a LET. And if it's people who are, a little bit older or they don't have these risk factors, mild instability, I can just do an ACL on itself. If I do a revision surgery and they failed and everything was done right, maybe I want to add a lateral extra-articular tenodesis. I want to decrease the rate of failure in the high-risk population. And it's been shown to do that in several randomized controlled trials. So I'm a big fan.
How much does surgical time play a factor with that?
It takes me about 10 extra minutes to add it.
Okay.
Yeah.
So it's the risk of staying. Okay.
No.
Interesting. That makes sense. What about, you were talking earlier about meniscus, like a bucket handle tear, or maybe, you're getting some of that catching, locking, or clicking. Where does meniscus transplant come into place when you're thinking meniscus repair versus transplant, let's say?
So the transplant comes into place when somebody had like a repair, for example, and then it failed. And then another surgeon went out and had to remove the torn tissue because it didn't heal. A great example of that, I actually did one, recently where collegiate athlete, she tears her meniscus, went to a fantastic surgeon. He did a, very nice repair. It failed. She went to another surgeon I know who's also a fantastic surgeon. He did the right thing. He saw it. It wasn't repairable at this point. He removed it. And now she had a lot of meniscus loss and a little bit of cartilage damage. So she's missing like 80-90% of her meniscus. High level athlete, works hard, did PT, did everything else that she could. She's beginning to develop more degenerative changes, right? Arthritis is coming. I don't want her to get so far that putting in a transplant's no use anymore, right? We want to put in a transplant before someone's arthritis gets worse. The meniscus is protecting your cartilage.
Right.
So I said, okay, let's go in and do this transplant. So we did a lateral meniscus transplant. We take it, we try to do it before someone's arthritis gets bad. We give them their cushion back. And by doing so, a lot of people will see good results in about 70 to 80% of people, even 10 years out. So you can be buying them 10 more years or so of a knee without them getting further or worsening degenerative changes, I guess the more correct way to say it is slowing their progression is the goal of degenerative changes in this bad arthritis. So we want to keep their native knee, keep their natural knee by giving them this transplant because they lost all this meniscus So re-providing their cushion, re-providing their shock absorber, and now their knee can last longer, and hopefully we delay the needs of things like knee replacements.
Is there a point in which it's too late to get that transplant?
Yeah, so when we say the indication, it's like that, or the contraindication, meaning that it's just, this is not a good idea to do it, is when someone already has grade 4, like end stage arthritis. Their cartilage is already spoken for.
Yeah.
So you putting a transplant in there isn't going to, slow anything down. There are a few surgeons out there that still believe that a percentage of patients have success with it. So if they're young, they're like, listen, what do I have to lose? They're 25, they're 30, they've had a rough go. I'm going to realign them. I'll put in the transplant, and now they have a cushion with a realignment, and they're central in their knee. Their weight's going right through the center. Maybe it'll buy them time. And they've seen, and they do like large case series. I've done a dozen of these, and here are the results. Success rate's lower than when you're a little bit more aggressive, but some people believe it's a good option. And I think what we have to remember in these situations is each patient is different. Each patient is unique. And we got to give them their best chance. And even though sometimes a surgery might have a 50 or a 60% success rate or 70, it's better than 0.
Yeah.
And you have to have an honest, communication, open communication with them, and let them know the pros and cons, and let them know the natural history of what will happen if they don't do it, and come to a good decision together. And the only thing you can do is be honest with them.
Yeah, that's a great point, because there are plenty of people that even try PT and maybe they may be unsuccessful entirely. Now that surgery may not have 100% outcome based on the evidence, but 50% of success rate is still amazing compared to where they're at if they've had this knee issue for many years, and they've tried the injections, they've tried PT, they've tried the they've done all the conservative things, and they've exhausted it. Now, that is the next course of treatment. And whether or not, it's 100% proven with the evidence, I know people get hung up with that stuff sometimes.
I think people nowadays want a home run. They want to know, they come into your office, whether it's your office or my office, they want a guarantee. Is this going to work? Yeah. And the only thing I always tell them is we're all humans, and we're doing our best to give you the best possible second chance at a more longevity with whichever limb or joint you've hurt, so you can keep doing all the things you want to do, right? We're giving you the best possible chance that we can, but at best we're batting 80 to 90% in that range. So there's a 10% chance that even if I do everything right, you might be unhappy. Right. The only thing I can promise you is that if you are unhappy, if you do have a complication, I will be a part of that journey afterwards. I won't just say, peace, it was nice knowing you, and send you to someone else. I will do everything I can to make things right. I will be on this journey with you. I will hold your hand through the process. And if it's something I can't do to help you, I will work my butt off to get you to someone that can help you, because I want to give you your best chance. I'm in on the journey. It's the only thing I can promise you, because there's no guarantees. Yeah.
No, I love that. I mean, that's the change that you're talking about, with being there on their side as a teammate versus a much more, I don't want to say transactional, but when the healthcare system is flooded and demand is so high, it makes it seem a little more like that versus being there with every step along the way. So what if you were able to give a piece of advice to your patients, the ones that oftentimes do get surgery, and you were to tell them something a couple years before you saw them in the office? If there's anything that you could have given them to potentially minimize their need for getting that surgery done in the first place, what jumps out to you?
Prehab. Yeah. I mean, was that a setup or what? I mean, I feel like,
well, the
I'm
question,
pretty sure right now that was an alley-oop, right?
It's funny because the original question was, what does prehab mean to you? But since you've been on and answered that, I wanted to word it in a different way.
No, that's awesome. You did that fantastically, by the way. You're excellent at your job.
Yeah, thank you.
But really though, is, we think about all these young ACL injuries, for example. What could they have done? We know for sure that we cannot make ACL injuries disappear. It's still going to happen, but we can decrease the rate at which they happen by doing a better job with, neuromuscular conditioning, right? Doing a better job with plyometric training and these things like our hip mobility. We figured out all the risk factors. What makes you a greater risk? So what can I do? I can strengthen more. I can have better single leg control. I can have better, strength, symmetry. And so all these conditioning, if they can do that, if they can spend more time on this injury prevention, I would love to see that, because there's nothing more heartbreaking than seeing someone who has an injury and you reconstruct them, or you're trying to help them and they come back again with the other knee injured, for example, or maybe they retore this one. Seeing them go through that process is absolutely heartbreaking.
Yeah, and that happens all the time. You brought up something at the beginning of the podcast, which is great too, with understanding load management of, like, you know, if you go from playing, let's say, paddle tennis 0 times a week to next week playing 5 times in a row for an hour, like, you know, yeah, you're bound to overdo something. You have to understand how to progressively load, and only playing a sport is not the way to train tissue. That's why there's that quote that has become popular where you don't run to get fit, you get fit to run, because you want to strengthen your tissues appropriately so that you can play that sport versus using that sport as your way of getting fit and strong.
That's, you know, I actually haven't heard that one, but it's a really great quote, because one of the most common things that people tell me is they tell me that they want to lose weight, but they can't go running anymore because their knee hurts. And one of my things to them is, well, first of all, we know dieting is a large part of losing weight, and dieting, you don't want to say that word, healthy eating, right? Healthy eating is a large part of losing weight, and we all struggle with weight, right? It's a normal part of life. But if you eat well, and maybe we can work on cycling or swimming or another activity that we can do to cut a little bit of the weight, right? Then you can go back to running, because now you're not running overweight. A lot of people say, oh, I hear running's bad for your knees. No, run. Actually, runners, there's evidence that shows that they have thicker cartilage, lifelong runners.
Yeah.
You know, so it's not bad for your knees. Running significantly overweight, though, is way worse for your knees, because your knees seeing 5 to 10 times your body weight. So if you love to run and you feel like right now you're 20 or 30 pounds overweight, let's, you know, work on our healthy eating habits, go back to, you know, different exercises that are a little bit more low impact, cut a few of the pounds, and then go back to running. You should never stop doing what you want to do. Our whole goal, our whole purpose of you being you and doing what you do and me doing what I do is to get everyone back to doing their dreams and their goals, so life is fulfilled.
That's a great point. It's like the dose is the poison. And if you talk about running, I recall a study talking about the risk of knee OA is actually high if you do 0 and a lot of running. And so you want to find your sweet spot. I think that it was somewhere between 3 to 15 miles based on a lot of factors with like weight and all that, a week, that is. But I'd have to dig that up. But the point being, you have to do something. It's better than nothing, but finding that sweet spot. I think much more people bias on the side of not doing enough than doing too much. But also preparing your tissues appropriately is a key piece of that.
Whatever gets you moving, whatever makes you feel good, you should do it.
Exactly.
You know? And let pain be your guide.
Yeah, right.
You know, I remember you and Mike taught me a really valuable point, one of our other podcasts, when you guys told me what you tell your patients about, we were doing a video together, you and Mike and myself, and you said that you always tell patients squat as low as you can. The squat depth is different for different people. You know, someone could have an impingement in their hip and it hurts you to go to 90 or 100, but you do it till 70. You're still gaining strength doing that. So keep doing it, but make your limit 70. And so I think we all should, that's a great lesson. We all should do our best to do anything we want to do and find our range, but still do those activities. Don't just stop doing them.
Right. No, that's a great point. And the first question I usually ask people when talking about their past medical history and doing a screen with their exercises is, what exercise excites you the most? Because that's the one that they're more likely to stay consistent with. Yeah. So it's important to see how people are motivated. But anyways, Dr. Nima, that was great. Where can people find more information about you if they want to follow up with you about anything?
Well, thank you. If they ever want to find me, they can definitely find me on Instagram. Under my full name, Dr. Nima Mehran. And I'm sure my good friend here will flash it somewhere. Yeah. Probably flashing like call 1-800. You can find our practice is actually in the Pacific Palisades now off Sunset and PCH. Nice. And we have a website, M&M Orthopedics. M&M is for Mehran and Muffley. My new partner, who's a good friend and a fantastic surgeon who also trained in large healthcare systems and in county systems. So, you know, in those systems, you get a lot of experience and it's a great place to train. And so I got a great partner with great integrity, and I'm excited to work more with Matt Muffley. And so if you guys ever need anything, come to M&M Ortho.
M&M Ortho. and that's, you said M&M
I'm in orthopedics.com. Yeah.
Okay, great. Thanks again for hopping on.
Yeah.
Hopefully you guys learned a lot. I mean, I really appreciate your time with this stuff, because I recall when first graduating school, having a lot of questions with post-op cases. And as a PT, I never got that time with an orthopedic surgeon to ask these questions. And so having these answers is very useful for any physical therapist, athletic trainer. And I know that we've gotten a lot of positive feedback with having you on before. So hopefully you guys learned something else on this third podcast with Dr. Nima here.
Thanks for having me, man. Always.
Thank you.